Hi everyone. We'll go through echo in CPR and as well as ischemic heart disease today. Be about 45 minutes. So let's start off with the exam question, which is normally along the lines of discuss your use of echo, or it might say discuss use of ultrasound in someone with a non-traumatic cardiac arrest. So let's talk through a little bit about how we might answer that question. Why don't we start with the guys here? We'll start with our guest of honor, Lewis McLean. Talk to us how you might want to try and answer this question, because it's, again, I think it's been asked once in the past before. I don't think it was done brilliantly, because I think one of the questions, this is the kind of question where it's, the important is to, think broad and make sure you don't miss out silly marks in there. And so we'll come up with a model answer and we'll talk about how we might want to separate out the marks for it. So take us through how you might want to sort of set this question up, Lewis.
So with the use of ultrasound in cardiac arrest, I think that the main modalities would be in defining the etiology, so diagnosis, which speaks to the reversible causes.
Yep, and just run me through those.
So the 4 H's and 4 T's.
But again, particularly it's how it's going to guide your management.
Yeah.
So again, I guess all the question, it's all about how it, it's all in the question. Yeah. So echo doing, so the 4 H's, 4 T's is not going to help you with hyperkalemia. So tell me about how echoes.
Particularly, I guess, with a PEA arrest, if you think about obstructed causes of shock, you would be thinking about tamponade, you'd be thinking about PE, you would be thinking about a poorly functioning LV for cardiogenic shock. You would be looking for evidence of wall motion abnormalities to help support the diagnosis of a myocardial infarction. Would also be, I guess, getting prognostic data in terms of what the heart looks like.
Can you guys all hear this, by the way? I hope you can.
Sorry.
Yeah, everyone okay? Cool.
Mm-hmm. Yeah, so I've gone on from diagnosis to prognosis. So prognostication in terms of the actual arrests, so looking for ordered cardiac activity, looking for evidence of a heart that might restart even.
Yeah. So, and how would you, what sort of bad prognostic sign? And
so cardiac standstills associated with a 0% survival. Slightly controversial, but probably with other indicators bad.
Yeah.
and spontaneous ordered cardiac activity can be considered a sign of life to progress to higher level therapy such as the ECMO in patients who would be appropriate.
Stay activity.
And then if you've got signs of chronic cardiac disease as an underlying comorbidity, then that would give you some prognostic information as well.
All right. Okay, let's go on to this thing. Raymond, help us out. How can we develop this a little bit more? So I'm not saying anything we got is wrong here. Help me fill in some of the gaps. So why don't we start with the diagnosis as well? So what are we looking for on the echo is signs of reversibility. And so I think we've said obstruction, PE, and tamponade, and absolutely that's right. We'd have to chuck in something there about what you're looking for. Talking about big blown out right ventricles, talking about an echo-free space with free wall collapse of the right atrium, left atrium, or right ventricle. Keep going for me, Raymond. Help fill me in some of these gaps.
Well, hypovolemia would be cavity obstruction.
Yep.
it can be difficult to distinguish that from a low systemic vascular resistance state, such as with anaphylaxis. But again, that would be very similar. Um, uh, I mean, I guess if you're talking more broadly about ultrasound use, you look at lung ultrasound as well. If you're not just talking about echo, so that also raises other possibilities of how we can use ultrasound.
Nice. If they're talking about ultrasound, you're absolutely right. We've got to be thinking about general ultrasound in there as well. So I'd be adding in the idea that if it just says echo, I think you can, I'd probably mention it, but I wouldn't stick too much time in there because I use the same probe. I think echo, they're generally just talking about the heart.
Right.
But ultrasound, bring in general ultrasound, because I also think you'd have things like, sudden cardiac arrest, non-traumatic, think about, I'll just write general. Thinking about the AAA, I think, is another obvious one that we'd have jumping out of there. And discuss the use, it's just mentioned a little bit. You don't have to go into super amounts of detail, I reckon, in some of this, unless it's what is asked in the question. So, yeah, keep going. Is there anything else? What else do you want to say?
We talked about regional wall version amenities. We talked about echo-free spaces outside of the heart.
Yeah. Again, diagnosis. We can use it for prognostic. Or
Management.
What else are the other things that we could potentially?
Oh, I see. Management. So you can use it to sort of guide your management.
Yeah.
So you can see the response to filling. You can see the response to pericardial centesis.
There you go. Nice. So we got a response to treatment. We can have guiding procedures.
Mm-hmm.
Beautiful.
I actually misinterpreted this question to think it was actually echo during cardiac arrest.
It absolutely, it could be. So this is what it is.
If what happens to a heart that's in the middle of an arrest, regardless of what the cause is, would it keep the same cavity size or would it just dilate up? That's one question. And then the other question, I think you'd see a large right ventricle if that was pre-existing.
So there's pig studies that demonstrate that the RV blows out regardless of the cause of arrest, but it blows out more in a stimulated pig.
Cool. So it's the same thing, I guess, we talk about every time. I feel like we go through a question like this, is talking about the clinical relevance of it. And, being clinicians doing this exam rather than sonographers. But everything that you've said is right. And of course, there must be something you write in this question about diagnosis. But I think some of the stuff that I really like in this is talking about this bit here. You've all done echo during cardiac arrests, I imagine. And I can't be the only one who thinks it's really, really bloody hard, right? So I think discuss the use of ultrasound during a cardiac arrest. For me, there are some pretty big motherhood statements to make in there. The first of all would say that it is not the focus of what is going on at that stage. Putting that echo probe on is an important part, but it's not in the recommendations of the major guidelines. They say it can be used. But the most important thing is that someone's doing CPR, right? So I would be saying in the intro, it's difficult. It should not stop CPR. Oops. And echo is an adjunct to help you with diagnosis, prognosis, and management. Yeah. So some of the challenges. So discuss your use of it. Absolutely, it's in here. But how the hell do you do it? So I think it's another one of those things that discuss your use of echo in the management of a patient with ARDS. Describe how you would do it. If we're looking at the RV and we say we don't want to set the pressures on the ventilator too much, say that, you know, if I change the ventilator, if I change the PEEP, or I change the tidal volumes, whatever, I'll go back and have a look at the echo. If I see the right ventricle dilating, I'll think about trying to turn down the ventilator. You know, you've got to answer the question and don't miss out silly marks. Like, so putting this in, you know, that there's a mark just for saying don't stop doing CPR. Where do you put the probe? How do you do it?
Well, you can't do a parasternal long or short.
No,
so you have to do an apical.
Down
You've got apical,
down
okay.
the esophagus.
So the esophagus, fantastic. So I'd say here you've got the challenge of doing it. It's only subcostal. I think the challenges are, echo windows are tricky. You've got sort of one of them. Echo windows, you've got maybe a few seconds between CPR. You know, I think I find it really hard to get any kind of a view that's interpretable at all when they're doing chest compressions. You're only doing it during CPR. Has anyone ever been able to diagnose a pneumothorax causing? So hang on, Raymond, I'm going to have a go. You mentioned this. Have you ever been able to diagnose a pneumothorax during CPR with the thing? I mean, I've looked for it loads and loads of times, you know, and you put it on there and someone's bag masking and I'm just, you know, I think it's really hard. So I'm going to say, you know, pneumothorax is a hard diagnosis to make during CPR. What other challenges have we got?
Sam, could I say, there's a very well-described protocol by Susanna Price's group, the FEEL protocol.
Oh, right, okay. I'm so sorry, I don't actually know. If you got a copy of that, would you be able to share it?
Yeah, I can send it out.
Send it to me and I'll put it on the Dropbox link. That'd be great. Tell me about the FEEL protocol.
So again, it's used to train people with limited training for assessment in cardiac arrest for all the reasons that you've stated. And I mean, the broad outline would be that CPR should not be, echo should not interrupt CPR, but there are scheduled pauses. That you use the most experienced practitioner, subcostal view first, but try anywhere that works. Record prospectively, ideally for 10 to 15 seconds. Set your depth to 20 to 25 in advance, low frequency. And they did a prospective trial, and they were able to get workable images in over 90% of people.
Nice.
So,
I'm not suggesting that we wouldn't be able to get pictures. I'm sorry if I...
Yeah. No, usable pictures, I suppose.
I find it hard, and trying to sometimes exclude a lot of this, I find more often than not that echo doesn't help me that much, other than with this prognostication. You know, maybe this is just my own experience, but as an examiner, I really like it when someone can, you know, bring in some of, you know, it's like in the SICM exams, you know, in my practice, I do this. And as long as it's not outrageously weird, you know, it sounds good. So, you know, I think I think it's nice to say that it's challenging and it's not as easy as it sounds with this. Yeah?
As well, Daniel Lichtenstein had his Sesame protocol that had been, again, describing this in prospective trials.
And sorry, what's the protocol?
Sesame. S-E-S.
EMI. Sesame.
Yep.
Sesame protocol.
Yeah.
If you don't mind, if you've got a copy of that, will you send that as
well?
Yeah.
I'll send it.
It's a FEEL protocol, F-E-E-L, focused echocardiography, something in life support.
Of course. The evidence that I know behind some of this is that prognostication, if you have standstill, that's generally been associated with a less than 1% survival. I'll see if I can find the reference for that. I'll pull that out as well. So again, when you're working through these questions, and I think this is kind of about it, I don't have much else to say. But of course, the first thing that we're going to jump to in our heads is to go through the diagnosis. Of course, you'd have to mention that. I reckon if we're going to put 15 marks to it, you know, we're definitely going to be saying that something like that is worth a mark. I think each of these would be worth a mark in terms of picking up obstruction, talking about obstruction, cardiogenic, hypovolemic shock, and the echo features thereof. We've got to talk about how to do it, which windows you're going to be going through. Prognostication would be really important in terms of management. I think that would get an extra one. Mentioning some evidence. And where are we up to at the moment? 1, 2, 3, 4, 5, 6, 7, 8, 9. At least the how to do it would be a really important one. So we said subcostal, between CPR, most experienced person, and we're getting pretty close to calling it there, I think. So activity, telling you to carry on. How much we got? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Always leave one left over. 13, 14, something like that.
Sam, could I ask you a question? It's really about sort of an exam question. If I was writing this, I do primary examining, and we would put a lot of effort into making sure that it's really clear what we're asking. So is this a cardiac arrest versus peri-arrest? You know, there's a very big difference. And also, I suppose, would it be really clear that we're talking about echo or critical care ultrasound?
Yeah, and absolutely. I think it would be made clear in the question. The one that I had in my head is something like, you know, the use of ultrasound in non-traumatic cardiac arrest. You know, say it would be very clear if it was peri-arrest or arrest, echo versus general ultrasound. Discuss your use in the management of. It'd be those kind of questions, I think, is generally where the exam has been trying to lead. And in that regard, you know, it's not just saying, what's the differential diagnosis of cardiac arrest with echo? You know, that's that question. But using ultrasound in someone who's having a non-traumatic cardiac arrest, that's the whole question, right? Under the terms of think broad and answer the question. Yeah?
Yep.
So when you're practicing, I think this is the kind of way to start going through it. You know, I'm trying to think about how many questions I can actually ask in the DDU exam, and I've only come up with like 50 of them, right? You know, in terms of cardiac arrest, there aren't that many ways that you can ask about it. It's really, really fair game, because I think it's obviously extremely critically care focused, and just try and make up these rubrics between yourselves so that we can, you know, in terms of trying to make yourself think broad. Okay. Any questions about that? Anything I've missed out, do you think? Just have a look. I've got a cheat sheet here from something I wrote before. I guess some of the other ones I've written down here about verification of tracheal intubation. You know, there is some in the emergency literature, they certainly talk about that sometimes. It's not something I'm hugely fond of. I don't think it'd be worth a huge amount of marks. I think if you do go down mentioning things like using echo for tracheal intubation, I'd be saying that the reference standard is always going to be, you know, CO2 monitoring after you've intubated someone. This is an adjunct. It's not in place of anything. That's about it.
I would say that different is that, and again, I'll send out the article, is that the evidence for what I do is different than what I should do. And that's a metaphor for life, but
you're being filmed, mate, by the way. We're recording this. What should you say?
I'm turning my good side to the camera.
Yeah, exactly. It's beautiful.
I would say there are, you know, we tend to think of the advantage of echo during cardiac arrest for H's and T's, trying to work out a differential, and then to guide procedure if there is a procedure such as a pericardiocentesis. But actually, the really big advantage is that it helps us with rhythm identification, that there's a very serious error rate, a misdiagnosis of asystole, when often it's fine V fib leading to a shockable rhythm. So you can just
what a great comment. What a great comment.
And even more importantly, the error rate in the diagnosis of this total bullshit concept called PEA, when there's no such thing as PEA. So it can separate out PEA into true PEA and pseudo PEA. And I think they're probably just as important as to diagnose obstructive causes of shock. And the evidence base isn't bad for that, actually, you know?
Very nice. So that's a great comment. Thanks, Gordon. I like that. I'll just press, I'll record this. I'll take a photo. I'll put it up on the Dropbox link. We'll go from there. All right. Should we go through a case?
Mm-hmm.
All right, so I'll give the case vignette first. So this is a mid 50-year-old man with a history of hypertension, hyperlipidemia, who was asked to perform an echo on in the unit. He had come to the unit following a Met call, where he essentially just looked really, really crap. So moribund. He'd been admitted with syncope and a troponin rise, called a non-STEMI, and had a Met call from a monitored bed. He was intubated and put on metaraminol infusion and went to the cath lab immediately, where they found occlusive triple vessel disease. Cardiothoracics didn't feel that he needed an emergent bypass, in that his vasopressor requirement was not that high. And they wanted some stabilization before they thought about transferring, and there was some bed availability issues. So he came to the unit, intubated on FiO2 of 30%, PEEP of 5, on a low-dose aramine infusion, and I performed this echo. So, do you want me to just?
Yeah, I mean, do you want to ask, maybe pull up an image or two? Does anyone want to have a go? Are they coming through okay at the other end?
Mm-hmm.
I say,
Yeah.
pick on someone and get them to report it, just so we can practice our banter.
Okay. Who's first? Raymond, you're first. You're first in line.
I'm always first. Am I? So in this peristernal long axis view, we're seeing that the LV is very dilated. The left atrium also looks enlarged. I'm very concerned about severe segmental dysfunction. I can see that the anteroseptal region is particularly affected compared to the posterolateral, but both are affected. The mitral valve annulus looks enlarged. And the coaptation is well below the annulus, so it does look restricted.
Yeah, excellent. And so putting color on that.
Can I just quickly make a quick comment? Ray, you talked about the walls of the ventricle, which is really great, because I think at some stage in the Viva exam, someone's going to ask you about which walls there are on an image, and can't just come out with them like that. The examiner's shackles, whatever you call them, the hairs on the back of their neck are going to go up. You know, you've got to be able to come out with the walls super fast, and saying the anteroseptal infralateral and not being asked is really great, and the examiner will like that. So just as you described that there, I thought that was really nice. You know, talking about LV size, LV function, the segmental wall motion abnormalities. I think I'd add in there talking about the poor opening of the mitral valve. Does that mean there's mitral stenosis there? No, it's probably just he's got a terrible cardiac output. You know, left atrial size, indicating probably a chronic component to this LV dysfunction. And it's important to note that the aortic valve looks okay. The right ventricle looks normal in size and function. There's not a massive pericardial effusion. So, you know, it's that banter that you had there was really good. So, you know, keep going with that.
So this is the color across the mitral valve in view.
Terrible.
Does Sid, do you want to describe that and tell us what else you'd like to know?
This is the eccentric mitral regurgitation jet, which is going across the left atrial wall. Difficult to comment onto the severity on this picture because of the angle, I guess. But I would want to know into the apical four-chamber view,
Allow me to find
density into the subjective density into the continuous wave Doppler, I guess.
Just scroll down and just go back to here and choose where it wants. Which one? April.
Okay. Yeah, I was just going to show them.
Sid, why is it challenging? Why do you find it difficult to estimate the severity on that?
Just because it's an eccentric jet.
Fantastic. And why? So take me through. So in the exam, you know, if you just leave it saying it's difficult to examine, the examiner, you know, he's going to ask it or she's going to ask it to you. So why is it tricky to estimate the severity of the mitral regurgitation with color Doppler on an eccentrically dilated, eccentrically directed jet? Yeah. Why is that difficult?
Because it's a three-dimensional problem, and then you're only looking at it one-dimensionally into the parasternal and long axis view, and you want to probably pan the probe across to the jet and look at the probably filling of the left atrium in other views as well, I guess.
Yeah, fantastic. Okay, so what would make you think that the mitral regurgitation was severe on color Doppler looking at mitral regurgitation? What's your cutoff for saying something severe with color Doppler? Yeah, do you hear me?
I'll pass that question.
Okay, so normally we say it's about 40%, or if you've got a color Doppler jet that fills 40% of the left atrium, that's associated with severe mitral regurgitation. What's different with the eccentrically directed jet is that there's something that causes the jet when it's eccentrically directed to stick to the wall. Does anyone know what that effect's called?
Go ahead now.
Yeah, beautiful, kind of effect. So if you say, you know, when you in the exam, when you say, you know, it's difficult to say the severity looking at color Doppler alone, and that's because of the Coanda effect causing some of the what would be kinetic energy with a centrally directed jet. The kinetic energy is unfortunately, you know, keeps it constricted to the side. So it's really difficult, as you said, to estimate severity of mitral regurgitation with color Doppler with an eccentrically directed jet. So, you know, the next question they're going to ask is, how are you going to determine the severity of this mitral regurg?
There are subjective and objective criteria for it, and obviously the size of the left atrium, the density as a subjective density in the continuous wave Doppler into the left atrium,
Nice.
the pulmonary valve inflow onto the pulse wave Doppler into the apical four-chamber view will give you some idea about the severity of mitral regurgitation.
Very nice. And the last one, E wave being greater than 1.2 flow into the left ventricle. Very nice. Thanks. Sorry to interrupt.
No, that's all right. Shall I? Yeah, sure. So that was the E wave there, and 1.2.
Almost 1.1.
So that's 1.2, and I think that if I scroll down, yeah. So Carsten, would you mind describing the image there? Carsten?
Come on, you're on mute, buddy.
Oh. Still on mute. Lex.
Hang on, buddy. Yeah, there you go.
Can you just move on from me for a second? I'm just tied up with something else. Sorry.
Yeah, sorry. Hatem, can you just describe what's on this image here?
This is pulse wave Doppler across the mitral valve in an apical four-chamber view, and I can see that there is a pattern consistent with at least moderate mitral regurg with the regurg flow across at -0.4 or -0.5.
This is pulse wave Doppler, and sorry if you can't see it well, but you've got let me just point out that, so this is when pulse wave Doppler, this is where the gate is. At the bottom.
Okay, so, yep.
So sorry if it's not clear.
Across the pulmonary veins, yeah.
Yeah, beautiful. So have a crack.
Across the pulmonary veins. And yeah, and it's revealing here that the jet is actually reaching the pulmonary veins with some retrograde flow across the pulmonary veins.
Yeah, and which stage of the cardiac cycle?
This in the diastolic phase. So diastolic regurg, which denotes
Almost. Sorry,
yes.
did you? I'll let Lewis. No, Lewis, you're doing a great job. Lewis, tell us about this picture. Just had to do a couple of things, just back to front there a little bit. So I'll let Lewis explain what this picture is and why he took it and what's abnormal about it.
Yep.
So you normally have SD and A waves, and the S waves not visible in this tracing, and there's a
No.
diastolic dominant wave, which would make you think moderate to severe.
Yeah, so normally you'd expect there to be a big wave in there. So normally the S wave during systole, so again, that's from the beginning of the QRS to the end of the T wave, you'd expect in a normal pulmonary vein flow to be bigger than the diastolic flow. So the end of the T wave to the beginning of the QRS. So big S, smaller D, and then a little bit of A wave reversal. And so what we're seeing here is there's no systolic flow at all, and that's because you've had the severe mitral regurgitation that stops blood coming into the atria during systole, and that's associated with moderate to severe. If you've actually got reversal of the systolic flow, that's absolutely associated with severe regurgitation.
That's a better explanation.
You do.
So severe.
Sorry, let's just let me just general.
So what's the diastolic wave that appears below the baseline?
Yeah, I wonder whether we just got a little bit of, I don't know, we've got quite a small volume. I'm not. Yes,
So is that an artifact? Because it often looks like it's mirrored the baseline, but
I'm not sure. I guess it's important to make sure that we haven't got any ghosting up here, so no abnormal, none of the red gates, or make sure you haven't sort of exceeded the Nyquist limit. And I can't see any of that there, so I think we've got a bona fide, and I don't know, I think it's just a little bit of fuzz. Maybe we're not quite catching the full flow as it comes out because it's eccentric in nature, and maybe this is just the tail end of systolic flow reversal. I think we've got enough features here pointing towards it being severe.
No,
so
I agree, but I just want to know where that comes from.
yeah, I don't know. Well, I think the big thing there is just we don't have the systolic flow in there, which points towards this significant. We use that wonderful term. Significant mitral regurg.
And for the sake of completeness, yes, I should have reduced the sector width. And all right, did you want me to?
So we were talking about ischemic heart disease. So let's just talk about regional wall motion abnormality.
Yeah.
And how you go about assessing regional wall. Because Ray, you were talking about, you said, I think you said that you thought that the anterosegmental wall was akinetic, hypokinetic. How do you?
Severely hypokinetic, I thought, from memory.
Yeah. Okay. So again, what's the terminology for regional wall motion abnormality? Take me through severities.
Oh, gosh. There's so there's do you want to know what I do practically, or what's written about to talk about?
I guess so. Just first of all, I just want to pick you up on your nomenclature. So you said severe hypokinesis.
Yeah.
So I guess my question to you is, how do you grade it? So the gradings are normal,
mild,
hypokinetic, akinetic, dyskinetic. Yeah. So we don't have akinetic. We don't have the aneurysmal anymore. So talk to me about how you make those diagnoses. So first of all, what's normal?
So normal has to involve thickening as well as shortening. So
thickening greater than
30%.
50%.
50%.
Cool. Yep.
50%.
Hypokinetic.
Anything from 0 to 50. I don't know.
And akinetic.
0.
0 and dyskinetic.
Is obviously moving the opposite direction.
Fantastic. So 0 moving in the opposite direction. Beautiful. So yeah, just in terms of making sure that the terminology is tight. Yeah, there's no severe hypokinesis. It's hypokinesis or akinesis.
Sure.
I
Yeah.
think I put that in the same category as sometimes our sonographers write the LV systolic function is reasonable or low normal. And I think we should try and be tight with our terminology, and it's either normal or not, mild, moderate, severe if we can. I'm certainly guilty of writing moderate to severe when I want to sit on the fence. But in the exam, just try and be tight with your terminology. And if you're not sure, say you're not sure.
Sure.
Thanks.
Should I
Yeah.
go through the short axis? I'll just move through the short axis views. Does anybody? No, I need to.
We've got Danielle's on there as well. She's hiding at the bottom of the screen.
Danielle, do you just want to describe these short axis pictures in terms of the grading system that we just discussed?
Sorry, maybe she's not there.
Okay. Carson, are you back online yet? Oh, you're on mute, I think.
Yep, no, I'm back, yep.
Did you just want to go through the parasternal long axis, discussing the grading in terms of wall motion abnormalities?
So this is a short axis view at the level of the mitral valve. And there is akinesis anteroseptally, anteriorly. Probably hypokinesis anterolaterally. So that's all I'm seeing. I'm just seeing one image. Yep.
Yep. And if I give you the mid pap.
Again, I would say that there is an akinetic segment anteriorly.
Hey, Ish, but I'm just going to.
Anterolaterally hypokinetic.
Yep. And the oh, sorry, the base move.
That's apical again. It looks to me. I mean, it looks to me akinetic anteriorly.
Yeah. So what was pointed out to me by the echocardiographer who I was with was the lack of the akinesis as evidenced by the essentially whole of the donut staying the same shape throughout the cardiac cycle, and that the movement that we were seeing was related to radial contraction rather than longitudinal contraction, because in the apex, in a longitudinally contracting ventricle, it should obviously move, the hole should get bigger and smaller as the ventricle contracts, and the radial contraction here is giving the impression of wall thickening, but in particular, this very experienced echocardiographer didn't feel like felt like that was akinesis of the apex.
So, Lewis, we've been, summary from what we've just been talking about, we were saying that the LA was enlarged, so we thought that there may be a chronic component to this. Yeah. And so it's not beyond the realms of possibilities to think this guy may have some chronic form of ischemic heart disease. How can you try and tell the difference between acute ischemic heart disease with these regional wall motion abnormalities versus chronic?
Acute versus chronic. Well, with chronicity, you're going to be looking for signs of ischemic cardiomyopathy. So you'll be looking for a dilated left ventricle. We'd be looking for a dilated left atrium.
Cool. So those are the 2D features. Anything else on 2D features? What about the actual myocardial segment itself? Yep, so we've got segmental wall motion abnormalities here. I'm just asking, is there any way that we could try and tell if this is a chronic or acute coronary artery ischemic changes?
Remodeling.
Yeah, nice. Yeah, exactly.
So,
yep, nice.
So wall thickness.
Yep.
Wall thickness.
Chronic, it would be
So if it's chronic, the wall thickness will be reduced.
Yeah, so thinned myocardium. Yep, and anything else about the myocardium? Because we're not really seeing it here. See, this looks like normal myocardium. I think it looks the same here where we've got akinesis versus over here. So typically if it's thinned and echogenic or scarred is one of the things.
Yep.
So thinned, echogenic and scarred is chronic changes, as opposed to normal looking myocardium that's not doing a lot could suggest chronic. It's not perfect, it's just a way. Okay, coronary artery disease territory, what territory
So in the mid-PAP view, this is something that I need to constantly revise, but LAD is essentially this part, so androseptal. Lateral is LAD or circ. And then posterior part, including the posterior part of the septum, is RCA.
RCA, very nice. Okay, so what other rules do we have about regional wall motion abnormality? Because I think if you're asked to talk about regional wall motion abnormality, first of all you have to describe which segments they are, and that's not saying septal or lateral. I think you've got to be talking about anterior, inferior, anteroseptal, inferoseptal, inferolateral, anterolateral. Be describing the 16 segment model, or 17 if you use it, and talk about which segments are abnormal. Be really wary, I think, of starting talking about if it's outside of a coronary artery territory. It can't be that one thing's dodgy over here and another one's there and it's sort of scattered around. That doesn't make sense. So it's got to be in a coronary artery territory. I think talking about acute versus chronic changes, so looking for that thin scarred myocardium versus normal thickness myocardium, and then talk about the coronary artery territory you suspect is involved. And my last rule would be to say, just maybe to finish things up, is to say, after we've talked about the segments, chronicity, coronary artery territory, is we want to back it up in two views. For regional wall, this short axis is my backup view. But for example, if I wanted to look at you said you thought the anteroseptal wall was down, which view would we want to go and have a look at to back that up? Or we've got the short axis view and we've got the apical 3-chamber view. You can double check it in that view. If we're worried that we think that we've got the, say, the anterolateral or inferoseptal, we know that we can go and have a look at our apical 4-chamber view. If I'm in the exam and I want to just look for those extra marks, I could talk about, I obviously use my short axis view as my sort of go-to view because it's hardest to mess up. But if I'm finding it difficult to do that, don't forget that you can get it from your subcostal view if you're trying to be, if you're trying to use all available resources. The short axis on your subcostal view with some off-axis imaging. Okay. Nice one. Thanks very much for showing us that case. So that sort of brings the DDU teaching to a close. Were there any final comments or suggestions from anyone?
Quick question, Sam. The wall thickening of 50%, I'm just looking at Benita Anderson's book and she's saying 40.
Oh, excuse me. I'm just using the ASE guidelines. Is what
perhaps it's changed.
Let me share and I'll take them. Not giving you porcupines. Let me quickly bring back my screen.
Pretty sure it's 50 in the ASE guideline.
It might have changed. Yeah.
So we'll just double check that while we've got.
Is that the 2017 version, Carsten?
I am looking at her new book, A Sonography of Heart Disease. Mine's a 2014 copy, so.
She's just released the 3rd edition of normal echocardiography.
Right.
There we go. So I can't see my screen. Let's see if we look at.
Yes, you got answer correct. Save all of that. Yeah. I now started making notes for the regurgitation.
You know what's going to make things easier? Louise, Louise, the definition of hypokinesis in Benito Anderson's book, it says 40. We had someone else saying 30. I was saying 50 as sort of guidelines. What do you think of the definition of hypokinesis? 50. There we go. Can't take that. What does Benito know? I've got Louise Smith.
Exactly. Yeah.
All right, guys. Thank you very much. I think we'll call it a day for there. I'll put this up on the website.
Thanks very much. Gotta go.
Thank you.
Bye.